Welcome to Black Health Matters. I'm Daryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Okay, interesting articles in the Post today about bionic eyes and being able to just see. They were talking about blind being able to see with bionic eyes and implants into the brain, so people who are paralyzed can walk again. And we're talking about the fact that women hearts take more beating from stress than men, and today we're having Dr. Ealena Callender talk to us about women's health. Dr. Callender is a graduate from the Mecca Howard University, but she did her medical school training at University of Maryland. Then finished her obstetrics and gynecological training in Wright State University in where's that, lady? Wright State is in Dayton, Ohio, right? Yeah. And then she spent the next 15 to 20 years actually at the Mayo Clinic and in different parts in Minnesota, and then came back to join us here in Maryland the last 5 years or so. So she's had a vast experience with obstetrics and gynecological issues, and today she's going to talk to us about women's health, and particularly for those of us who are beyond 50 or so. So welcome, Dr. Ealena Callender. It's nice to have you again. You were on before a year or so ago, and we're thrilled to have you with us again.
Morning. I'm happy to be here. Do you want me to start now?
Yes.
Okay. Let's see.
Welcome.
Thank you.
This is so exciting.
I like your last name too.
Let's see. Okay, share my screen. Okay, everybody can see this?
Yes.
Okay, so today I'm going to talk about women's health and particularly gynecological cancers. But I'm going to focus on some of the differences between how these present and are diagnosed in women, in Black women. And I'm going to start out with a story about some cases where Black women were misdiagnosed. So this is starting with a young lady named Jessica Petway, and she was a beauty influencer. She was on Instagram and all those things, and it had a lot of attention for her impact in that way. But she ended up dying at the young age of 36 from cervical cancer. Let's see if I can go away. So in June of 2022, she was hospitalized multiple times due to heavy vaginal bleeding, and she required blood transfusions. She was told at the time that she was having these symptoms because she had fibroids, which is a common GYN diagnosis, especially in women of color. This was new to her, that this heavy bleeding was new to her, but they found fibroids, and the people that she saw decided that that's why she was having this heavy bleeding. By February of 2023, she was diagnosed with advanced cervical cancer after finally seeing an oncologist. And a year later, in March of 2024, she had died from cervical cancer. And as we'll talk about during this time, we will learn that cervical cancer is one of the most treatable and preventable of GYN cancer. So it's extremely unfortunate that she died at such a young age from a cancer that doesn't have to kill people. The next story. The next story is about Adrienne Moore. She was a 45-year-old respiratory nurse in Atlanta. In 2012, she started having pain and bleeding with intercourse and irregular periods. She was told that it was because of perimenopause, or she was in the years approaching menopause, or that she had ovarian cyst, or that it was fibroids. She had no improvement over the next 3 years. She saw multiple doctors and still was not diagnosed. After missing work due to worsening pain, she ended up losing her job and her health insurance. And then she went another year without getting any care because she didn't have a job or health insurance. When she got another job, she finally was able to see a doctor who did diagnose her with advanced endometrial cancer. So it had been 4 years before she got a definitive diagnosis. Fortunately, Miss Moore was able to undergo treatment and she is now in remission. So I'm going to talk about some of the racial disparities in gynecological cancers. Black women often are unfortunate enough to have misdiagnosis and delayed diagnosis of these cancers. Black women experience higher rates of death from many GYN cancers than white women. And women and racial and ethnic minorities are 20 to 30% more likely than white men to experience a misdiagnosis. So these are some of the common sites of GYN cancers. There's cervical, which we talked about in the first with the first case, ovarian, endometrial, vulvar cancer, and vaginal cancer. Cervical cancer, as I mentioned, is one of the most preventable and treatable types of GYN cancer, or of cancer overall. Screening and vaccination are key to prevent the disease. Everyone has heard of the Pap smear, and that is a test that helps with screening, and it can find abnormal cells very, very early in the process so that cancer never has to happen. And we also have a vaccination that can prevent those cells from ever changing into cancer. Unfortunately, still in 2020, there were more than 600,000 women who were diagnosed with cervical cancer worldwide, and almost 350,000 died from the disease. So cervical cancer is caused by HPV, human papillomavirus. This is a sexually transmitted virus that causes the majority of cervical cancers. Most women, by the time they reach the age of 50, will have been exposed at some point to this virus. In the United States, more than 4,000 women do die from cervical cancer each year. It's most often first diagnosed between the ages of 35 and 44. It is the fourth most common cancer in women worldwide and the fourth highest in cancer-related deaths, in spite of how preventable and treatable it is. Black women are 80% more likely to die from cervical cancer than white women. For white women, the 5-year survival rate is 67%, but for Black women, it is only 56%. Non-Hispanic Black women make up a disproportionate number of new cervical cancer cases and are more likely to be diagnosed at later stages. So normally if a woman gets Pap smears at the recommended intervals and continues to see her gynecologist, cervical cancer doesn't really have to happen at all. And if we started before that with the vaccinations, it makes it even less likely to happen. But so in order for so many women to be dying, people are missing out on these resources. There was a study that allowed researchers to document factors that were contributing to the disproportionate cervical cancer deaths in Georgia. And they were looking at some of the reasons that are behind the increased rate of death among Black women in Georgia. In Georgia, Black women are almost 1.5 times as likely to die of cervical cancer as white women, and these disparities increase at alarming rates as women age. Black women in Georgia are more likely to have never been screened for cervical cancer, meaning they've never had a pap smear in their entire lives. They are more likely to be diagnosed at a very late stage, and they have a lower survival rate at 5 years after diagnosis. In the study, Black women described callous treatment from their medical providers, an inadequate level of care, and concerns about confidentiality. These issues undermine the trust that they have in doctors and alienated them from gynecological care, thus contributing to poor reproductive health outcomes. So because of all these things, women didn't receive maybe didn't even know about and definitely didn't receive vaccinations, or didn't know about pap smears or the recommendations for how to get them, or just didn't get them. So when cervical cancer is diagnosed at an early stage, the 5-year survival rate is 90.9% for white women, and still at an early stage, it's lower at 85% for Black women. When it's diagnosed after it has spread beyond the cervix, the survival rate drops to 17% for white women and 15% for Black women. So you can see here how extremely important prevention and early detection is for this type of cancer. And as I said before, we do have resources for these. So there are multiple issues that are preventing women from accessing these resources. Some of the symptoms of cervical cancer include unusual vaginal bleeding, a change in a woman's vaginal discharge, pain during intercourse, lower back or pelvic pain, persistent urinary tract infections, constipation, leg swelling, and bone pain. But again, these are cervical cancer symptoms. These are symptoms that may occur once a woman already has cancer. But these are signs to look out for. If any of these things happen, it's important that a woman go see her doctor. Again, prevention, starting at age 9, the HPV vaccine called Gardasil is available for boys and girls. Starting at age 21, it's recommended that every woman start getting pap smears and HPV testing. From age 30 to 65, women can get pap smear testing alone, or HPV testing alone, or HPV and pap testing together. So the difference is that the pap smear actually gets a sample of cells that a specialist looks at under the microscope. HPV testing tests for the presence of the virus that causes cervical cancer. After the age of 65, women don't need cervical cancer screening if they previously have been negative and they've had 3 normal pap smears or 2 HPV tests in the preceding years. If they have a history of abnormal pap smears or surgery due to abnormal pap smears, anything like that, then the recommendations change. So ovarian cancer is the #1 cause of deaths from gynecological cancer in the United States. About 20,000 women are diagnosed each year, and 13,000 women die from ovarian cancer each year. It is very different from cervical cancer in that we don't have the resources in order to prevent it and treat it. It's most commonly seen in women most commonly diagnosed in women over the age of 55. Also in women with a history of breast cancer, ovarian cancer, colon cancer, or endometrial cancer. It's more common in women with a personal history of themselves having breast cancer. And it's more common with certain genetic mutations and syndromes, mainly the BRCA1 and BRCA2 gene, and Lynch syndrome, which is a genetic syndrome that involves a certain subset of cancers. It's women who have never had children are at higher risk. Women who have a history of infertility and who have a history of endometriosis are at higher risk of getting ovarian cancer. But ovarian cancer is most often asymptomatic. And if there are symptoms, they are very vague and can also be associated with a variety of health issues. So if you have any of these symptoms, it's important to see your OBGYN and get a pelvic exam. And the symptoms, like I said, are vague, like bloating, pelvic or abdominal pain, trouble eating or getting full really quickly when you do eat, going to the bathroom very frequently, having an upset stomach, heartburn or constipation, back pain, feeling tired, any kind of changes with your menstruation and pain during sex. So as you can see, these are things that people may experience at one time in their life or another. And they may be considered, as part of some sort of stomach upset situation, like a GI problem, or just, another one of those things that happens. But it's important to know that any of these things are signs and symptoms that should make someone go see their doctor, especially if they have any of the risk factors that we mentioned before. Endometrial cancer, this picture shows the uterus and the endometrial lining. So the endometrium is the lining inside the uterus. It's the place where, inside the uterus is where the bleeding comes from. That lining is where bleeding comes from when a woman has her period. And that is, we're talking about cancer in that area. It is also referred to as uterine cancer. It is the most common type of reproductive cancer, and the second after ovarian cancer, second deadliest gynecological cancer in the United States. Most cases are diagnosed in women who are past menopause and in their mid-60s. The age-adjusted mortality is 84% higher in Black women than in white women. Risk factors. Risk increases with age, so being beyond menopause increases your risk. Conditions such as obesity, diabetes, and some of the genetic cancer syndromes that we've discussed. A history of polycystic ovarian syndrome, meaning when a woman is menstruating, she may have symptoms like irregular periods or infertility and pelvic pain. Also, a history of breast cancer that has been treated with the drug tamoxifen increases the risk. Starting a woman's period at a young age or going through menopause at a late age can increase the risk. So basically, that means having periods more, starting earlier and ending later, and also never having been pregnant. So if you've never been pregnant, you've also had more periods in your lifetime than someone who has been pregnant. Signs and symptoms. The most common symptom is vaginal bleeding after menopause. It's important to note that any amount of bleeding after menopause, also known as postmenopausal bleeding, is abnormal. Okay, so even if it's just a spot and it's just one time, it's a reason to go see your doctor. So any irregular bleeding when a woman is having a period, so heavier bleeding, even lighter bleeding, bleeding in between periods, that is a sign or symptom that can be consistent with endometrial cancer. Symptoms of advanced endometrial cancer include abdominal or pelvic pain, painful intercourse, bloating, feeling full quickly when eating, changes in bowel or bladder habits, and unexplained weight loss. And you can see some of these are overlapping with the other cancers that we've already discussed. Racial disparities in endometrial cancer. Black women are nearly twice as likely to die from endometrial cancer as white women, even though the disease is slightly more common among white women. There are aggressive forms of endometrial cancer that appear to be more common in Black women. Black women with a history of uterine fibroids have a 40% higher risk of endometrial cancer. And this is according to a study done at Boston University. Compared with white women, Black women have 2 to 3 times the incidence of uterine fibroids, an earlier age at first diagnosis, and greater disease severity. So unfortunately, Black women are also less likely to be evaluated based on established guidelines when they do present to the doctor with symptoms that may be consistent with endometrial cancer. Black and Hispanic women are less likely to receive surgery, hysterectomy, or definitive surgical treatment. Minimally invasive surgery is performed less frequently in Black and Hispanic women. Black and Hispanic women are also less likely to have lymph node sampling or dissection at the time of surgery. And this is important because it can detect if the cancer has spread. Black women are also less likely to receive chemotherapy after they've had surgery for treatment of endometrial cancer. The recommended workup includes just, we start out with a history and physical exam. Next, transvaginal ultrasound is commonly done, and this is done to look for abnormalities in the uterine lining. The ultrasound can look at whether there's a mass that's inside the uterine lining, or if it's abnormally thick, especially in women who are postmenopausal. So unfortunately, this test is often done as an initial test, and but it can be done as an initial test, but it should not be the only test. It cannot determine that you do not have endometrial cancer. It can, if a woman has a very thin lining in her postmenopausal years, it is less likely that she has endometrial cancer, but it's not definitive. So it's one place to start, but it shouldn't be the only test, especially because Black women have a much higher incidence of uterine fibroids, and the presence of fibroids can make it more difficult to miss cases of endometrial cancer when using an ultrasound. Ultrasound scans that measure the thickness of the uterine wall are less accurate when patients have the more lethal non-endometrioid type of uterine cancer, the cancer which is more common among Black women. So it may not be an appropriate test for Black women really at all to initially evaluate them with symptoms of endometrial cancer. The definitive test would be an endometrial biopsy, which is in this picture, we can see like a small, sort of like a very thin straw that goes inside the uterus and removes a sample of tissue that we can send to the lab, and the experts can look at the cells and determine if there's any cancer present. Hysteroscopy means using a small camera that essentially goes in the uterus the same way, and we can look around and actually look at the lining of the uterus. And that this is usually done in along with a DNC, which means dilatation and curettage, or again, going through the opening in the cervix, getting into the uterus, and actually getting a sample of tissue. So scraping to get a sample of tissue. So the definitive diagnosis would involve getting actual tissue from the lining of the uterus to determine if cancer is present. So, we've talked about a lot of the disparities and the delayed diagnosis and misdiagnosis. So I want to talk to you more about how you can advocate for yourself, and you can make sure that you get the best treatment, and you make sure that your concerns are heard. So one of the important things for us to do is to make sure we know our own family history. And a lot of times we don't like to talk to each other about our family history, but it's very important that we know what's going on. It's important to ask our family members about their history of any gynecologic disorders or other medical problems, any history of surgeries or special tests that they've had done. This information can help you and your doctor better understand the risk factors that you might have for certain cancers. If your tests are negative, but you still have symptoms that you're worried about, keep asking questions. I say there may be another type of doctor you should see for further evaluation, but if you're not satisfied, don't let that be the end of it. And, ask your doctor if there's something that they recommend that you do to further evaluate what's going on with you. Also, it's always important to tell your doctor about any symptoms that you notice, even if you don't think they're related. Keep notes about your concerns and bring those with you to your appointments. As we went through the list of some of the symptoms, they're kind of all over the place. It can be increased frequency of urination or an upset stomach. So you may not think that like an upset stomach has anything to do with a GYN cancer, but it may. And there may be some connections that you may not recognize, but the doctor may be able to recognize it when he or she sees the entire picture. Also, it's important, I think, to keep a diary of symptoms and details such as time of day and any relationship to meals or certain activities, and to be very specific. Your doctor, when doing your history and physical, will ask you lots of questions. And that is only to make sure that you do get the best care. It's important to know, all the W's, and also what makes your pain better, what makes it worse, what have you tried to make it better, what worked, what didn't. And even things like time of day can be important. So it's important to take notes before your visit and also take notes during your visit, so that you may not think of questions at the time of your visit, but you might think of something later when you go home after you review the notes. So it's important to keep notes, and so you can make sure you understand everything that goes on during your doctor's visit. And another way to help with that is to bring someone with you to your medical appointments. This person can serve as an advocate and may be a spouse, an adult child, another family member, a close friend, or even a community volunteer. It's definitely 2 sets of ears can be better than one. There may be something that you miss, but that your friend or family member remembers. So, and especially if you're really nervous or anxious about what's going on, you definitely might miss things. So, and also your spouse or the person you bring, they may remember things that have happened that you may not remember, or you may not think are important. So that can be a good way to help make sure that the doctor gets the complete picture of what's going on. It's also important for you to ask questions, and ask questions such as, what else could this be? If the doctor says, oh, I don't think it's this, then ask, well, what is it? Because something doesn't, or what could it be? Because you still don't feel well, something's still happening. So you want to know what are the other possibilities, and also ask what's next. Are there any other appointments? Do I need to come back and see you? Are there any tests that I need to have done? Do I need to go someplace else and get lab work, go someplace else and get an ultrasound or something like that? And also you want to know what you can do yourself, like how can you monitor your symptoms? What should you look out for? What should you be concerned about if this happens or that happens? So some of the sources that I have listed here are useful sources of information. Most times it's important, if you do go online, you look at sources that are from the government, so that have .gov or .org. The .org means it's a nonprofit organization that does not exist just to make money. And .gov, of course, means it's the government. So the CDC.gov has a lot of information about all types of cancers, but especially gynecological cancers that we're talking about. The American Cancer Society's website also. Memorial Sloan Kettering Endometrial Cancer Equity Program is a special resource for endometrial cancer. And they're looking at health equity, so that Black women, they're looking at making sure that Black women get the care that they are supposed to get. And this other one, Endometrial Cancer Action Network for African Americans, is also looking at health equity for Black women and endometrial cancer. So those are very good resources that you can look to for more information. And that's the end of the slideshow. Are there any questions?
Thank you for that very excellent presentation. One of the questions that I have before we get to others is, at what age can women stop seeing gynecologists? For example, if you're over 60, do you still need to go see a gynecologist, even though you may not need a pap smear or a HPV test? You still need to go see a gynecologist?
Yes, absolutely. Always go see your gynecologist forever.
On a yearly basis, or how often?
That's something that you might need to discuss with your gynecologist, but we love to see you every year. Every other year might be appropriate. But it's definitely, a lot of women think that once they stop having babies, they don't need to see a gynecologist anymore, but it's important to continue seeing that doctor. You might have a lot of other issues going on that you see a primary care doctor for or other specialists, but it's definitely still important. Those organs are still there and they still can cause issues that other types of doctors may not recognize. And like, as we talked about with all those different types of symptoms that can occur, they may not be thinking of a GYN cancer. And they may think that the upset stomach is just an upset stomach. But if you go to a gynecologist and go regularly, even if you might just talk to them about what's going on with you, you may have no idea that those things are related to a GYN cancer, but they'll notice those things. So I think it's very important to continue going. And, if there is a point at which you and your doctor feel like it's not necessary to go anymore, then it's definitely something you should discuss with your doctor if you decide that that's going to be the case.
Another question.
I-
As you analyze what happened with those 3 cases you presented at the beginning of the presentation, what are your thoughts as to how the doctors could have made such egregious errors?
So, it's really, for both of those women, there are very simple tests that could be done that could have prevented them from going through what they went through, and the first woman prevented her from dying. I mean, you really have to, I can't say this enough, listen to women. I do see amongst all different kinds of physicians and healthcare providers that it's not uncommon for people to not listen to women's symptoms and to justify them by saying it's just this or it's just that. And so I think really just comes down to that we need to listen to women. And that's, if we have people out there who are not listening, that's why it's important for us to know more and to know that we need to ask more questions and that we need to advocate for ourselves. Because the tools are there. Endometrial cancer is much more common. It's a pretty common cancer, but it's also very easily diagnosed. And I mean, first of all, a woman has to know that, like, the most common complaint would be postmenopausal bleeding. Women have to know that that's a problem, even if it's a little bleeding. It doesn't have to be a lot of bleeding. It doesn't have to be 14 days, it could be 1 day, they have to go first. And the doctor has to understand that, any woman who's having this kind of complaint should be fully evaluated. So I think, the study that was done in Georgia, the purpose of that study was to really describe some of the barriers that women face and hopefully to, spread the word and make sure that we can raise awareness about some of these barriers and address them.
Mr. Tatum, you had a question?
Yeah, I want to thank her for a very thorough presentation. You covered all the areas, and that's good. I wanted to ask a question. Women are under a lot of stress.
Yes.
And I wanted to ask you what role stress plays in a woman's gynecological health.
Well, it plays a role in her overall health. I think stress is a reason that a lot of women put themselves down low on their list of things to do or priorities, because they are responsible for so many things and they have a lot of weight on their shoulders. And all of that stress leads to things like inflammation and lots of health complications. We like obesity, high blood pressure, diabetes, all of these can be affected by stress, which causes changes in our bodies that lead to these these specific health issues. So it's definitely, it definitely plays a role, a very big role.
Thank you. Mary Ellen had a question.
Ms. Brooks? You're on mute. You're on mute, Ms. Brooks, or?
Yeah, Mary Ellen, you're still on mute.
Thank you. Thank you, Doctor, for a good presentation.
Thank you.
And that's something that's very important to me, to be my own advocate.
Mhm.
After I turned 65, now I'm getting ready to be 73. Doctors kept telling me I didn't need to have gynecological exams. And I resisted that and insisted that I have one.
Good for you.
And, because it's my body and I'm trying to be a good steward of my own body.
Exactly.
My mother had breast cancer. I had another doctor tell me I didn't have to have mammograms after 70. My mother had breast cancer at 92.
Mm.
It presented itself on the outside and not inside. But the fact is, as long as I have these body parts, I'm getting them all checked. You don't check them, I'll find somebody that will check them. If Medicare don't pay for it, I don't care. I'm
Yeah,
gonna get it done anyway.
that's
So that's my
you really are. You're being a good steward. I like that. I like that idea. That's true. You do have to fight for that sometimes, and I hear that too when I hear patients tell me as a gynecologist that they've been told they don't need to see me, and that is distressing.
right.
Thank you.
Dr. Perez.
Wow, 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 wow.
Hi.
Hi. I don't know if I'm floating as high as your father, but wow. Wow. Oh my, it's just wonderful to get the information and to get the information in a digestible form.
Great.
Talk about legacy. Talk about legacy. And you titled it An Emergency.
Mhm.
And everything that you talked about was reproductive justice across the lifespan.
Yes.
And I have to say that so many of our young women and so many of across the lifspan of womanhood, we do not see how critical it is that we be a part, that we vote. Because if we do not vote, so much is at stake.
Yes.
And seeing that you have to, if we shut down during reproductive ages, women see gynecologists, they're not seeing anybody else. So if you shut down those services, then we disproportionately will be impacted.
Exactly. Yeah.
With the disparities that you talked about for older women, we have got to talk to our young people. We have got to vote.
Yes, absolutely. Right. Because like you're, voting and choosing our own representatives, that has an effect. Why is it that in rural Georgia there are no providers that these women can see? These are things that happen because of legislation, and that these are impacted by who votes and how we vote.
Carol Tatum.
Thank you very much. Wonderful presentation.
Thank you.
Okay, being an older woman, I was thinking that I don't need one. So how do I go about, besides going on the internet, and asking my male primary care doctor, which is the best gynecologist to get. Female, male. I used to have a female gynecologist, but I had a hysterectomy, but she's moved out of town.
Mhm.
And are women better at listening to other women, or it doesn't matter? You just have to, like Russian roulette, get a female or male, and how do you pick one that will listen to me?
So Miss Brooks thinks women are better. I don't really have an opinion about that because I've met both women who listen and women who don't, men who listen and men who don't. So I don't think that in and of itself is a deciding factor. I think you can start by talking to other women that you know that live near you or close by or something, that they can find out if they're going and who they might be going to. You can check with your whatever your insurance is and see what's available in your area. And you can, I mean, I think probably word of mouth is the best way. Now, you know, you can always change, right? If you go to somebody and you talk to them and you feel like they are not listening, they don't seem to care, that you don't feel like they are understanding your priorities or your concerns or your needs, then it's time for you to decide, you know, what's best for you. So it's hard to know how well someone is going to listen just by, you know, seeing their name on a page or just knowing if it's a man or a woman. So it's important that you meet them and or talk to other people and see what they think.
Okay, we had a psychologist or anyway, Dr. Robinson.
Oh, yes.
He said he would interview, and he had a line of questions of how he would interview his next doctor, and he gave us those questions. But I was saying, for you, what questions would you ask a gynecologist just to see if they would be appropriate, and say, I would like to interview you before I hire you as my gynecologist?
Well, I would talk to them. I would ask, first I would tell them about some of my concerns and, you know, I would want to know, how they manage some of the things that you might be dealing with. I would want to know, how they, what their recommendations are for screening and diagnosing certain types of cancers. And how they respond. I would want to know definitely how do they manage something like if you have a problem, how will they address it? You know, like if I call you on this day because I have this problem, like, are you going to see me in the office? How long will it take for me to get an appointment? If you're not available, is there someone else available to see me? Things like that, like sort of like logistics or, you know, responsiveness. It's probably important to know how not how many, but like how much experience they have with people who are like you, like with Black women, with people in your age group, with, you know, people who have similarities to you. You know, it's like it'd be different. Like if you may not want to go to a practice where everybody there is an OB patient, right? They're all having babies. You might want to see someone who has more of a balance throughout the lifespan, you know, young women, even older women, you know, OB patients, GYN only patients, and, you know, like a broader range, or even a limited range, but a limited range that includes you.
Okay, and one last question. And I hope I don't get edited out. Race relations. Some people think that all Blacks are more concerning, but there are some Blacks that are racist or biased, to say. So I wouldn't want someone to think, or is that wrong? You know, are all Blacks not, you know, bias men or women, because I was looking at that report. It's our biases that make us not
Right.
diagnose the right thing. Because you look at them and just say women particularly can bear the pain, they're Black, and they don't have it as far as whites.
Right. For one thing, you want to feel comfortable. And again, if you're looking around the waiting room and everybody's pregnant, maybe that's not the place for you. If you're looking around the waiting room and nobody looks like you, then maybe that's not the place for you too. But that's part of that question that I was saying, like, how you want to know if that doctor sees patients that share similarities with you, whether that's race, age, what part of the country you live in, rural versus urban, things like that. Because you do want them to be culturally appropriate for you and what your needs are and what you're going to bring to them. I can't, I don't, definitely race is important as in this country. But you also want to make sure that each individual, right, is best suited for you.
Okay,
There
and
could
one
be
last,
some white doctors who spend all of their time, their entire practice is Black women who look exactly like you, right? Maybe that's true. But there might be a Black man doctor who's out in the suburbs and never sees any Black people. So,
okay, one last question.
mhm.
Besides you, availability. Who's your gynecologist, or are you available?
Unfortunately, I'm not available because I don't have a personal practice of my own. I work mostly in hospitals right now, and I mostly do either GYN surgery or take care of women delivering babies. And I live in Silver Spring, Maryland, and there are several practices around here that are I mean, there's definitely several Black women practices, and several OBGYN practices in the area that I think are appropriate. But I think you have to find who works for you personally and whatever issues that you might be dealing with. And you may even, I don't really have a gynecologist right now. I see a primary care doctor who is a women's health specialist, kind of. So they do GYN at that office. It's not just like, I know some women go to the doctor and they don't take off their clothes, they don't put on a gown or anything. So at this office, they do the exams, they do the pelvic exams, all of that stuff within the primary care practice.
Okay, Betty, and then Mary Ellen.
Yes, good morning, everyone. And again, Dr. Callender, that was an excellent presentation.
Thank you.
But my question, I am a senior citizen, as most people can see. I will be turning 80 next month, but fortunately, and I definitely say fortunately, I really have no health issues, to the point that my primary physician, we do telecommunication rather than having me go into the office. Okay. But I'm going to give you a little history. I started my menstrual cycle when I was 12.
Yeah.
And it ended at 48. And shortly after that time, I have not really seen a gynecologist. So I listen intensely to all the symptoms, because I do have a friend of mine that had endometriosis. So I listen to all those symptoms. I have had none of them. Presently I don't take any medications. So I'm just wondering, do you think at this stage of my life, I still need to go and have an exam?
I do. Well, maybe if you had been going consistently,
Okay.
I might say,
Alright.
okay, maybe not. But so you haven't seen a gynecologist since you, like in 30 years, something like that?
Probably not.
Then, I mean, so there are lots of things that, like when I see patients, just when they get up on the table and I do a pelvic, just a visual exam of the area, like I might see something that needs further evaluation just by looking. You know, you may not even have symptoms, but just by looking, I might see something. And that's also true, you know, for the entire exam. And there are also things that women think, you know, we sometimes think we know what it is. And so we just say, oh, that's just that, it'll be gone in a few days or something like that, but maybe not, right? Like, so maybe a little bit of itching, you just say, oh, that's no big deal. But maybe it is, because, you know, it may not be such a big deal when you were 30, but now that you're in your 70s, it could be vulvar cancer, you know? So like the little things that you just you just poo-pooed before, they might be something else, right? And so a simple exam would be very fruitful for things like that. So since it's been so long for you, I would say it's important to go. If you had been going regularly, maybe it would be a time to stop. You know what I'm saying?
Mhm.
And it sounds like you have good communication with your doctor, so you know, maybe that would be fine. So, but just looking, I think, is very important.
Okay. Okay, that answered my question.
Thank
Mary
you.
Ellen and then Dr. Perez.
Thank you, doctor. I started my period at 8 years, 11 months and ended my period when I was in a trial, uh, a trial surgery where they were starting to do embolism of fibroids.
Uh-huh.
And that was one of the complications. They said if you did that, you could stop your period. So I signed up right away. My question is, are girls maturing earlier now? Because when I matured, I was I was unusual.
Right, right. Mm-hmm.
In that I was 9 years old, but I looked like I was maybe 12 or 13 years old.
Okay.
You know, with breasts and tall,
Okay.
you know, but I'm just wondering, are girls maturing earlier now? And I'm telling you, in my mind, what I would have liked if they had not let me have a period until I was 12 years old, suspended a period. Do they do that? Do they stop
No,
it from having a period, or
no.
do they delay puberty?
Only, well, nowadays they do it, you know, for transgender issues, but there's no medical indication to do that because it comes earlier than you know, other people.
Right.
Why you said you would have liked that because
I wasn't ready. I was a child.
mhm. Yeah,
And it let me be the prey of
uh
like I was like the
dirty
little lamb
lion.
for the wolves.
Yes, yes,
So I had great supervision and my parents and everything. But
right.
I think nowadays children have I think it's such a predatory.
Yes. Well, I think it always has been, you know,
Right,
I
right.
think
I
we
just
have,
want
yeah.
I just wonder about that if girls are becoming mature often, because I often see young girls that are, you know, are mature, but are young in age, but look a lot older.
Physically mature, yeah, and actually, I'm just reading about that the other day, that is true. Little girls are starting their periods earlier, which means they are physically maturing earlier overall.
Right.
So it's definitely a problem for Black people, right? Because we
Right.
are often assumed to be more
Older than
mature
young.
than we are, right? So like it gives people, kind of an excuse to treat a 10-year-old boy or girl as a grown man or woman
Right.
because they look big, but they're still children. So
Right.
it raises concern. And I said, but the important thing, like you mentioned, that is that you have parents who protected you. And so we have to have parents who understand how their children are viewed in the world and make sure that they are prepared to protect themselves or help protect them from those things. But
Thank you.
some of that has to do with changes in diet, and things like that in overall, like as on a population level, that more people are maturing earlier.
Right. Dr. Perez and then Daryl Armistead.
My question was answered. And I guess, do you have recommendations on how we can be good disciples of this information?
Talk to your friends, talk to your family, right? Like I think a lot of us, we're too secretive about things and we need to share more with each other. And I think that will uncover a lot of misconceptions, that people have. And that gives us an opportunity, if we just talk about these things, it gives us an opportunity to share with each other what we know. And your friends or family members or whoever, they can share what they know. And so I think it's important to be open about your health. Of course, not to a level, that violates your privacy, but just to, we need to share things with each other. It's important for me to know if my sister's having an issue or if my cousin is having an issue, because maybe that will happen to me. Or maybe if I learn about what my sister's going through, then I'll know what to watch out for, things like that. So I think that's probably the most important thing, to just talk to each other more.
Daryl Armistead and then Sylvia Davis.
Yeah, thank you, Dr. Callender. That was an excellent presentation.
Thank
Okay, going back to the start of your presentation, you were showing the three young ladies where their deaths could have been prevented. And, I think as Dr. Perez was saying, how can we be better disciples or stewards of this information to make sure that it's disseminated? And we do have this, we do have the recording of this group session. And to be honest with you, right now, the recording the group session is 1 hour, 4 minutes long. If you share that as too long, nobody's going to watch it. But on the other hand, your presentation was about 20 minutes, and that's a lot more watchable. So I'm going to make a recording of the entire group session, but I'm also going to edit out just your presentation to 20 minutes, and I'm going to have that as a separate link. And I would love it if everybody could share your presentation with all of their women friends, all the women in their families, social media, Facebook, YouTube. It's too long for Instagram or TikTok, but I think it's valuable information. And we may not be able to save the world with that 20 minutes, but if we save just 1 or 2 or 3 people among our friends and associates, then it's all worthwhile.
Right, that's great.
Outstanding.
Very good. Sylvia Davis.
Thank you, Dr. Callender. It was a very detailed and very interesting presentation.
Yeah.
I wanted to talk about my daughter. She had fibroids removed. And when I saw the picture of the fibroids, I saw how large they were. And I was wondering, she had indicated that her OBGYN had just indicated, well, she didn't really have to have them removed at that time, but I had noticed the bloating and I told her, you need to go and tell her you want these removed. And I was trying to figure out, why would not the doctor, at what point when when a doctor is doing an examination and they see the fibroids, that they would say, we need to remove them now. And I was just wondering if there was some signal or something as you do the examination that the fibroids, they thought they were 4 and they ended up being more. And I was like, why did not your doctor do this earlier?
So fibroids are, it's like they're dense muscle masses within the uterus. Sometimes they grow out, like they extend out from the uterus. Sometimes they make the uterus just itself very large. But in and of themselves, they're benign masses. So they're not cancerous, they're not in and of themselves harmful. They can cause, I'm sorry.
Yes, I would like to ask a question.
Who said
I
talking?
don't know, because I don't usually
But did
chime
she
in.
answer?
But
Wait a minute, did she answer Sylvia's question though? Did she
Okay.
finish answering
I'm sorry.
Sylvia's question?
I thought Sylvia was finished.
I'm kind of new to this, so I'm just kind of learning how
No, that's
to
okay,
go
but just
Sylvia,
about.
did you
let her
finish?
finish
Did
responding
you
to
finish,
Sylvia first.
Sylvia?
Okay.
Not quite,
Okay,
not quite.
okay.
Just hold on. sister.
All right, yep, we'll come to you next. So by themselves, they don't cause harm. They cause harm if the patient feels harm. Like you said, your daughter was having bloating. Because of their size, they can cause pain, they can cause heavy periods.
Bleeding, yes.
Yeah, they can cause problems with urination or bowel movements, or just feel full, right? So if it's a problem for the patient, then it's a problem. Another problem, you may not have any of the pain and stuff, but maybe it's interfering somehow with, someone who's trying to get pregnant. So again, if it's a problem for the patient, then it's a problem. Like if I get an ultrasound or some sort of imaging study, because let's say I fell off my bike, right? And they look and they say, oh, by the way, you have fibroids. I don't need to have them taken out because I didn't know they were there. I don't, they don't bother me. You know what I'm saying? But if they
Yeah.
bother the patient, then that's a reason to do something about it. But you can remove them, but they're, depending on the symptoms, you might be able to treat the symptoms also. So surgery is the only way really to address it. But essentially, you address it if the patient is having a problem with it.
Okay, so then I think at one point she said she went to a nurse and they recommend between removing the fibroids and a hysterectomy. And I understand in the past that's been the practice, that many of the doctors would just go ahead and do hysterectomies. And I was concerned that even came up in her discussion with her nurse.
Oh, unfortunately, that still will come up, right? I mean, it's an option, right? Some people will choose that because they want to be bothered with their uterus anymore, I guess, so some people will choose that, but it is a bigger surgery, most likely. But there are definitely other options. You can remove the fibroids. Like I said, you can treat the symptoms in multiple ways. And there are definitely surgeries that can be performed that are focused on maintaining your uterus. Like Ms. Brooks was saying, she was in the study about our uterine artery embolization. That's a way to manage pain and bleeding from fibroids. So there are lots of different modalities. So hysterectomy is one option, but it's not anywhere near the only option. There are many options. So it's good that, that's what I mean. Like your daughter came to you and she said, well, the doctor said this and this and this. And you say, I don't know about, so those conversations should happen. You know what I'm saying? Like we need to talk to each other. And if we think something's not right, it's important to say so. And maybe that will encourage your friend or family member to go ahead and ask more questions.
Okay, thank you.
So Ms. Pearl?
Yes, my question is, I enlisted, thank you for your presentation. It was very informative. And I have had several of the symptoms that you mentioned. I've had fibroids removed and a couple of the other things. But my question is actually about having hot flashes.
Okay.
At my age, and I will probably be, I may be the oldest person on here, but I am still having hot flashes, and will soon be 86 years old. So I just wondered if that having the hot flashes had anything to do with, some of these other things that you mentioned.
I don't know necessarily that it's correlated with any specific cancer. Is that something that you talked to your doctor about?
Yes, I've talked to my doctor and my gynecologist because I do still see a gynecologist,
Okay.
and they just tell me, I have to live with it.
If, hot flashes can be related, of course, we think of them as related to it's usually the years around menopause, like you're saying, doesn't usually continue forever. But there are other hormonal issues or even like thyroid issues that can cause that. Yeah, so I would, I would want that to be evaluated to make sure that it's not something else. And there might be blood work that can be done, things like that, they might have already done that. I'm not sure, but just to make sure that it's not something else that.
Well, they've done several things. I've
Yeah.
had, a couple of exams, and as I say, I've just been told it's just some people just have them, more or less.
But there also are other medications that you can try that can help with hot flashes. So I would talk to see if they've done these tests and it's not something else, then there are medications that you can try to help make you more comfortable.
All right, thank you.
You're welcome.
Just to reiterate what my sister just said about hot flashes. I know we had a discussion one time at church, the younger women with the older women, and the older women told us that we would have hot flashes the rest of our life. So I don't know.
And I'm having them.
That's exactly what I mean in older women in my sister's age group and older. That's what they say.
That's terrible. And I mean, if it's interfering with your life, if it's making it so you can't sleep, if you can't go places, you can't do things, like if it's interfering with your life, then definitely I would seek some way to manage it, like maybe medication or something that would help. When you're in the early years, like when you're around the age of menopause, then we do think of estrogen, but it went much later, there still are other things that can help.
Dr. Callender, why resisted to talk about hormonal therapy for hot flashes, which is well known to respond to hormonal therapy? I notice you've resisted the opportunity to address that. Can you?
Yes, absolutely. So hormonal therapy is very effective at treating the symptoms associated with menopause during the transition. And if someone starts it when they are going through that transition, then it's fine to keep taking it. Some of the reasons that people have been wary of it have been like increased risk of breast cancer, endometrial cancer, and things like that. And also heart disease. But it has been shown that the types of treatments that we use now for hormonal replacement therapy do not cause those problems when they are used at the time when menopause, when that transition is happening, and then they can be tapered off, within some years after that happens. it is not necessarily safe to start it 20, 30 years after menopause, because your body has changed a lot and will respond differently to the estrogen. So in that situation, it's not the go-to treatment or management for those kinds of symptoms. If you had started it, when that initially happened, then maybe it's fine to continue it, but because there are many women who do continue it really indefinitely. But to start it many years after is much more complicated and not necessarily recommended.
Dr. Callender, I'd like for you to dispel a rumor for me, and that is that because a woman doesn't have kids at her early age and varying ages, they develop fibroid.
Fibroids?
Yeah.
Oh, that is not true. Many women have fibroids, women who actually the risk of fibroids isn't related to having children or not having children. Those things are related to some cancers, like the risk of endometrial cancer is increased if you have never had children, and ovarian cancer.
Okay.
But just fibroids, they kind of just happen. And as we mentioned, it happens more often in Black women, but we don't necessarily know why. But some people know they have them, some people don't. Some people have them and they might even have a big uterus because they have fibroids, but they still may not have any symptoms.
So you're saying that not related to fibroids, but some of these cancers are related to not having children.
Yes.
Right.
Dr. Callender, another question regarding fibroids.
Of course.
And can you address the regrowth of fibroids once they're removed?
Yeah, so it would not necessarily be that they're the ones that are removed are growing again. It'd be just new fibroids.
New fibroids.
Yeah.
Okay.
Yeah.
Oh, I see.
So, that uterus has a tendency to make fibroids, probably, right? So sometimes women will go, sometimes they may be permanently cured of whatever symptoms they were having, but sometimes it may be several years and then they start having symptoms again. But it's more like the uterus just has a tendency to do that, and it will continue doing it when given the opportunity.
Okay, and the other thing, you brought up a very interesting topic when you addressed for the transitions that you use medication to stop periods. What other type of medications are used going through this transition? And are there medications that one individual has to take for the rest of their lives?
To stop periods, or?
Well, if they're transitioning from a female to wanted to be, a male.
Oh, to a male. Yes, I believe they have to take it for the rest of their lives. Yes. I mean, they're probably different doses because puberty, right? There's like this flood of hormones. But then they would probably need like a maintenance because their whole lives, they're fighting their physiology, essentially.
Oh, and if they don't take those medications, things revert back?
They may not, actually, because those medications can cause permanent changes. Like if a woman takes testosterone, especially during those very important years, when she is becoming a woman, I guess, her voice may deepen, she might have hair growth in certain places, and that may not be reversible.
Thank you.
Mm-hmm.
Okay, I guess we've run out of questions, and
Very good questions, very good discussion. Thank you.
Yeah, I would like to, on behalf of the group, to thank you very much for that excellent presentation and the discussion of the questions thereafter. And So,
It was
Thank
truly
you.
fabulous. It
I'm so
was
glad to see you here, Lucy. Nice to see you.
a generation in the making. Oh my gosh, I'm so proud of you. And
Oh,
so
thank
proud
you.
of you.
okay, thank you very much. And we can't thank you enough. And I'll send you a letter to let you know how much we appreciate it.
All
You're
right.
both so kind to us.
It was great to
So,
be here.
okay, so I think that ends the group session.